Hello guys, today I will discuss about viral hepatitis in children. Viral hepatitis is caused by the 5 pathogenic hepatotropic viruses recognized to date, hepatitis A, B, C, D, and E viruses. Many other viruses and diseases can cause hepatitis, usually as a component of multi-system disease. This includes herpes simplex virus, cytomegalovirus, Epstein-Barr virus, varicella zoster virus, HIV, rubella adenovirus, and others. The hepatotropic viruses are a heterogeneous group of infectious agents that cause similar acute clinical illness. In most pediatric patients, the acute phase causes no or mild clinical disease. Morbidity is related to rare cases of acute liver failure in susceptible patients or to the development of chronic liver disease and its complications. When we see issues common to all forms of viral hepatitis, often what brings the patient with hepatitis to medical attention is clinical icterus with yellow skin and mucous membrane. The liver is usually enlarged and tender to palpation and demarcation. Splenomegaly and lymphadenopathy might present, and extrahepatic symptoms such as rashes and arthritis are more commonly seen in hepatitis B virus and hepatitis C virus infections. Clinical signs of bleeding, altered sensorium, or hyperreflexia should be carefully taught because they mark the onset of encephalopathy and acute liver failure. Regarding differential diagnosis, the differential diagnosis varies with age of presentation, and during newborn period, infection is a common cause of conjugated hyperbilirubinemia, and the infectious cause is either a bacterial agent and a non-hepatotropic virus such as enterovirus, CMV, and herpes simplex virus. And also during neonatal period, metabolic disease such as alpha-1 antitrypsin deficiency, CF, and tyrosinemia can be differential diagnosis for viral hepatitis. Anatomic causes such as biliary atresia and choledochocystis are other differentials, and inherited forms of intrahepatic cholestasis should always be excluded. Whereas during childhood, extrahepatic obstructions, inflammatory conditions, immune dysregulations, infiltrative disorders, toxins and medications, metabolic disorders, and infection with other non-hepatotropic virus and other parasites or other bacterial etiology can be a differential diagnosis, so those things should be ruled out. When we see the pathogenesis, the acute response of the liver to hepatotropic viruses involve a direct cytopathic and or an immune-mediated injury. The entire liver is involved, but necrosis is most marked in the central lobular areas, and the lobular architecture remains intact, although balloon degeneration and the necrosis of single or groups of parenchymal cells commonly occur. Bile duct proliferation, but not bile duct damage is common. In fulminant hepatitis, parenchymal collapse occurs on the described background. With recovery, the liver morphology returns to normal within 3 months of acute infection. In chronic hepatitis, the inflammatory infiltrate settles in the periportal areas and often leads to progressive scarring. Both of these hallmarks of chronic hepatitis are seen in case of hepatitis B virus and hepatitis C virus. When we see common biochemical profiles in acute infectious phase, acute liver injury caused by these viruses manifests in 3 main biochemical profiles, which serve as an important guide to diagnosis, supportive care, and the monitoring in the acute phase of infection for all viruses. The first one is, as a reflection of cytopathic injury to the hepatocytes, there is a rise in liver enzymes such as ALT and AST. The magnitude of enzyme elevation does not correlate with the extent of hepatocellular necrosis and has little prognostic value. There is usually slow improvement over several weeks, but AST and ALT levels lag the serum bilirubin level, which tends to normalize first when the patient improves. Rapidly falling aminotransferase levels can predict a poor outcome, particularly if their decline occurs in conjunction with a rising bilirubin level and a prolonged PT. And the other is cholestasis. Cholestasis is defined by elevated serum conjugated bilirubin levels, result from abnormal bile flow at canalicular and cellular level because of hepatocyte damage and inflammatory mediators. Elevation of serum alkaline phosphatase, 5-nucleotides, and the gamma-glutamyl transpeptidase levels and mark cholestasis. The third one is altered synthetic function, which is the most important marker of liver injury. And synthetic dysfunction of the liver is reflected by a combination of abnormal protein synthesis such as prolonged PT, high INR, and low serum albumin levels, metabolic disturbances such as hypoglycemia, hyperammonemia, and lactic acidosis, and poor clearance of medications dependent on liver function, and altered sensorium with increased deep tender reflex, which is a sign of hepatic encephalopathy. Monitoring of synthetic function of the liver should be the main focus in clinical follow-up to define the severity of the disease. After I have said this all about viral hepatitis, let's start from hepatitis A specifically. Hepatitis A is the most prevalent form, and this virus is also responsible for most forms of acute and benign hepatitis. And hepatitis A virus is an RNA virus and a member of picorna virus family. And this virus is heat stable and has limited hosted range, namely human and other primates. Also, fulminant hepatic failure due to hepatitis A virus can occur, and this is rare and it occurs more often in adults than in children. Transmission of hepatitis A virus is almost always by person-to-person contact through the fecal-oral route, and the mean incubation period of this virus is around 3 weeks, and fecal excretion of the virus starts late in the incubation period, and it reaches its peak just before the onset of symptoms. And this fecal excretion resolves by 2 weeks after the onset of jaundice in older people. The patient is therefore contagious before clinical symptoms are apparent and remains so until viral shedding cases. When we see clinical manifestation of hepatitis A virus is responsible for acute hepatitis only, and often this is an inactive illness with clinical symptoms indistinguishable from other forms of viral gastroenteritis, particularly young children. It is characteristically an acute febrile illness with an abrupt onset of anorexia, nausea, malaise, vomiting, and jaundice. And the typical duration of illness of hepatitis A virus is from 7 to 14 days. Regarding diagnosis of hepatitis A virus, acute hepatitis A virus infection is diagnosed by detecting antibodies to hepatitis A virus, anti-hepatitis A virus, which is IgM, and anti-hepatitis A virus is detectable when the symptoms are clinically apparent and it remains positive for 4 to 6 months after acute infection. A neutralizing anti-hepatitis A virus, which is IgG, is usually detected within 8 weeks of symptom onset, and it is measured as part of the total anti-hepatitis A virus in the serum. Anti-hepatitis A virus, which is IgG, confers long-term protection. When we see complications of hepatitis A virus, although most patients achieve full recovery, distinct complications can occur. Acute liver failure from hepatitis A virus infection is an infrequent complication of it, and those at risk for these complications are adolescents and adults, but also immunocompromised patients or those with underlying liver disorders. The height of hepatitis A virus viremia might be linked to the severity of the hepatitis. Hepatitis A virus can also progress to prolonged cholestatic syndrome that waxes and wanes over several months, which causes pruritus and fat malabsorption. And also, this syndrome occurs in the absence of any liver synthetic dysfunction and resolves without sequelae, but it needs antipruritic medications and fat-soluble vitamin supplementation if prolonged cholestatic syndrome occurs from hepatitis A virus. Regarding treatments of hepatitis A, there is no specific treatment for hepatitis A virus, and supportive treatment consists of hydration, antipruritic agent, and fat-soluble vitamins for prolonged cholestatic form, as we have said above. Serial monitoring for signs of acute liver failure, which is less likely to appear, is still important. And the prognosis for the patients with hepatitis A virus is excellent, with no long-term sequelae. The only field complication is a rare occurrence of acute liver failure. Regarding prevention of hepatitis A virus, patients infected with hepatitis A virus are contagious for 2 weeks before and approximately 7 days after the onset of jaundice, and they should be excluded from school, childcare, or work during this period. Careful hand washing is necessary, particularly after changing diapers and before preparing or serving food. In hospital settings, contact and standard precautions are recommended for 1 week after onset of symptoms. Regarding vaccines for hepatitis A virus, the availability of 2 inactivated highly immunogenic and a safe hepatitis A virus vaccine has had a major impact on the prevention of hepatitis A virus infection. Both vaccines are approved for children older than 12 months, and they are administered intramuscularly in 2 divided doses, with the second dose given 6 to 12 months after the first dose. Seroconversion rates in children exceeds 90% after an initial dose, and it approaches 100% after the second dose. And the protective antibody titer persists for longer than 10 years in most patients. The other hepatotropic virus is hepatitis B. And hepatitis B is a member of Hebdanavidae family, and it has a circular, partially double-stranded DNA genome. The surface of the virus includes particles designed as the hepatitis B surface antigen, and the inner portion of the virion contains hepatitis B core antigen, which is a nucleocapsid that encodes the viral DNA, and a non-structural antigen called the hepatitis B E antigen, a non-particulate soluble antigen derived from hepatitis B core antigen by proteolytic self-cleavage. Hepatitis B E antigen serves as a marker of active viral replication and usually correlates with the hepatitis B virus DNA levels. Replication of hepatitis B virus occurs predominantly in the liver, but also it can occur in the lymphocyte, spleen, kidney, and the pancreas. Hepatitis B virus has been detected worldwide, with an estimated 400 million persons chronically infected. Hepatitis B virus is present in high concentration in blood, serum, serous exudates, and in moderate concentration in saliva, vaginal fluid, and the semen. Efficient transmission occurs through blood exposure and sexual contact. Risk factors for hepatitis B virus infection in children and adolescents include acquisition by IV drugs or blood products, contaminated needles used for acupuncture or tattoos, and sexual contact, institutional care, and intimate contact with carriers. No risk factors are identified in approximately 40% of cases. The incubation period ranges from 45 to 160 days, with a mean of approximately 120 days. In children, the most important risk factor for acquiring hepatitis B virus remains perinatal exposure to hepatitis B surface antigen positive mother. The risk of transmission is greatest if the mother is hepatitis B E antigen positive, and up to 90% of these infants become chronically infected if untreated. Additional risk factors include high maternal hepatitis B viral load and the delivery of prior infant who developed hepatitis B virus despite appropriate prophylaxis. In most perinatal cases, serologic markers of infection and antigenemia appear 1 to 3 months after birth, and this suggests that transmission occurred at the time of delivery. Immunoprophylaxis with hepatitis B immunoglobulin and hepatitis B vaccine immunization given within 12 hours of delivery is highly effective in preventing infection, and it protects more than 95% of neonates born to hepatitis B surface antigen positive mothers. Infants who fail to receive the complete vaccination series have the highest incidence of developing chronic hepatitis B virus. Hepatitis B surface antigen is inconsistently recovered in human milk of infected mothers, so breastfeeding of a non-immunized infant by infected mothers does not seem to confer a greater risk for hepatitis than does formula feeding. The risk of developing chronic hepatitis B virus infection, defined as being positive for hepatitis B surface antigen for longer than 6 months, is inversely related to age of acquiring it. The risk of chronic infection is 90% in children who acquire it when they are younger than 1 year, and it's around 30% for those who acquire it when they are at 1 to 5 years of age, and around 2 to 5% for adults. When we see pathogenesis, the acute response of the liver to hepatitis B virus is similar to that of other viruses, and hepatitis B virus, unlike the other hepatotropic viruses, is a predominantly non-cytopathogenic virus that causes injury mostly by immune-mediated process. The severity of hepatocyte injury reflects the degree of the immune response, with the most complete immune response being associated with the greatest likelihood of viral clearance, but also the most severe injury to hepatocytes. When we see clinical manifestation of hepatitis B virus, most acute cases of hepatitis B virus infection in children are asymptomatic, evidenced by the high carriage rate of serum markers in persons who have no history of acute hepatitis. The usual acute symptomatic episodes is similar to that of hepatitis A and C virus, but might be more severe and is more likely to include involvement of skin and the joints. The first biochemical evidence of hepatitis B virus infection is elevation of serum ALT levels, and it begins to rise just before development of fatigue, anorexia, malaise, and at approximately 6 to 7 weeks after exposure. The illness is preceded in few children by serum sickness like prodrome, marked by arthralgia or skin lesions, including urticarial, purpuric, macular, or maculopapular rash. Other extrahepatic conditions associated with hepatitis B infection in children include polyarthritis nodosa, glomerulonephritis, and aplastic anemia. Jaundice is present in approximately 25% of acutely infected patients and usually begins approximately 8 weeks after exposure and lasts approximately 4 weeks. In the usual course of resolving hepatitis B virus infection, symptoms persist for 6 to 8 weeks. The percentage of children in whom clinical evidence of hepatitis develops is higher for hepatitis B virus than for hepatitis A virus, and the rate of acute liver failure is also greater. Most patients do recover, but the chronic carrier state complicates up to 10% of cases acquired in adulthood. Cirrhosis and hepatocellular carcinoma are only seen with chronic infection. When we see the diagnosis of hepatitis B virus infection, the serologic profile of hepatitis B virus infection differs depending on whether the disease is acute or chronic. Several antigens and antibodies are used to confirm the diagnosis of acute hepatitis B virus infection. Routine screening for hepatitis B virus infection requires assay of multiple serologic markers such as hepatitis B surface antigen, anti-hepatitis B core antibody, and anti-hepatitis B surface antibody. Hepatitis B surface antigen is an early serologic marker of infection, and it is found in almost all infected persons, and its rise closely coincides with the onset of symptoms. Persistence of hepatitis B surface antigen beyond 6 months defines the chronic infection state. During recovery from acute infection, because hepatitis B surface antigen levels fall before symptoms wane, IgM antibody to hepatitis B core antigen or anti-hepatitis B core IgM might be the only marker of acute infection. Anti-hepatitis B core IgM rises early after infection and remains positive for many months before being replaced by anti-hepatitis B core IgM, which then persists for years. Anti-hepatitis B surface marks serologic recovery and protection. Only anti-hepatitis B surface is present in person immunized with hepatitis B vaccine, whereas both anti-hepatitis B surface and anti-hepatitis B core are detected in persons with resolved infection. Hepatitis B E antigen is present in active acute or chronic infection and is a marker of infectivity. The development of anti-hepatitis B E termed seroconversion marks improvement, and it's a goal of therapy in chronically infected patients. When we see the complications, acute liver failure occurs more commonly with hepatitis B virus than the other hepatotropic viruses, and the risk of acute liver failure is further increased when there is co-infection or superinfection with hepatitis D virus. As mentioned, hepatitis B virus infection can also result in chronic hepatitis, which can lead to cirrhosis, end-stage liver disease, and hepatocellular carcinoma. Membranous glomerulonephritis with deposition of complement and hepatitis B E antigen in glomerular capillaries is a rare complication of hepatitis B virus infection. When we see treatments of hepatitis B infection, treatment of acute hepatitis B infection is largely supportive. Close monitoring for liver failure and extrahepatic comorbidity is a key. And the treatment of chronic hepatitis B virus infection is in evolution, and no one drug currently achieves consistent, complete eradication of the virus. The goal of treatment is to reduce viral replications, defined by having undetectable hepatitis B virus DNA in the serum and the development of anti-hepatitis B E antibody, which is termed seroconversion. The development of anti-hepatitis E transforms the disease into an inactive form, thereby decreasing infectivity, active liver injury and inflammation, fibrosis progression, and the risk of hepatocellular carcinoma. Drugs that are commonly used for hepatitis B treatment include interferon, lamivudine, adifovir, and tenofovir. Adifovir and tenofovir is used mainly for children older than 12 years, and lamivudine and entecavir is used for children older than 2 years of age. Regarding prevention of hepatitis B, the most effective preventive strategies have resulted from the screening of pregnant mothers and the use of hepatitis B immunoglobulin and hepatitis B vaccine in infancies. In hepatitis B surface antigen positive and hepatitis B E antigen positive mothers, a 10% risk of chronic hepatitis B virus infection exists compared to 1% in hepatitis B E antigen negative mothers. Mothers with an hepatitis B virus DNA viral load more than 200,000 receive an antiviral such as lamivudine or tenofovir during the third trimester, especially if they had a previous child who developed chronic hepatitis B virus after receiving appropriate prophylaxis. Hepatitis B immunoglobulin is indicated only for specific post-exposure circumstances and provides only temporary protection for 3 to 6 months. It plays a pivotal role in preventing perinatal transmission when administered within 12 hours of birth. Regarding universal vaccination, 2 single antigen vaccines are approved for children and are the only preparation approved for infants younger than age 6 months. And 3 combination vaccines can be used for subsequent immunization dosing and enable integration of the hepatitis B virus vaccine into the regular immunization schedule. For a baby born to hepatitis B virus infected mother, post-vaccination testing for hepatitis B surface antigen and anti-hepatitis B surface should be done at 9 to 18 months. And if the result is positive for anti-hepatitis B surface, the child is immune to hepatitis B virus. If the result is positive for hepatitis B surface antigen only, the patient should be counseled because it's already infected. And if the result is negative for both hepatitis B surface antigen and anti-hepatitis B surface, a second complete hepatitis B vaccine series should be given and followed by testing for anti-hepatitis B surface to determine if subsequent doses are needed. The third one is hepatitis C infection. Hepatitis C is a single-stranded RNA virus classified as a separate genus within the Flaviviridae family with marked genetic heterogeneity. It has 6 major genotypes and numerous subtypes which permit the virus to escape post-immune surveillance. Genotype variation might partially explain the difference in clinical course and responses to treatment. Globally, an estimated 58 million people have chronic hepatitis C virus infection, with about 1.5 million new infections occurring per year. When we see mechanism of transmission for hepatitis C virus is a blood-borne virus, and it's most commonly transmitted through the reuse or inadequate sterilization of medical equipment, transfusion of unscreened blood and blood products, injecting drugs used through the sharing of injecting equipment, and sexual practices that lead to exposure to blood. Hepatitis C is not spread through breast milk, food, water, or casual contact such as hugging, kissing, sharing food, or drinking with an infected person. In children, perinatal transmission is the most prevalent mode of transmission, and perinatal transmission occurs in up to 5% of infants born to viremic mothers. HIV co-infection and high viremic titers in the mother can increase the transmission rate to 20%. And the incubation period of this virus is around 7. When we see the pathogenesis of hepatitis C virus, the pattern of acute hepatic injury is indistinguishable from that of other hepatotropic viruses. In chronic cases, lymphoid aggregates or follicles in portal tracts are found, either alone or as a part of general inflammatory infiltrate of the portal areas. Hepatitis C virus appears to cause injury primarily by cytopathic mechanisms, unlike that of hepatitis B virus, but immune-mediated injury can also occur. The cytopathic component appears to be mild because the acute illness is typically the least severe of all hepatotropic virus infection. When we see clinical manifestation, acute hepatitis C virus infection tends to be mild and insidious in onset, and acute liver failure rarely occurs. And hepatitis C virus is the most likely of all these viruses to cause chronic infection. Of affected people, less than 50% clear the virus and the rest develop chronic hepatitis. Chronic hepatitis C virus infection is also clinically silent until a complication develops. Serum aminotransferase levels fluctuate and are sometimes normal, but histologic inflammation is universal. Progression of liver fibrosis is slow over several years unless comorbid factors are present, which can accelerate fibrosis progression. Approximately 25% of infected patients ultimately progress to cirrhosis, liver failure, or occasionally primary hepatocellular carcinoma within 20 to 30 years of acute infection. Chronic hepatitis C virus infection can be associated with small vessel vasculitis and is a common cause of essential mixed cryoglobulinemia. So as you see on the table, acute infection of hepatitis C virus causes symptoms only in 20 to 30% and 50 to 25% clears the virus, and the 75 to 85% will go to chronic infection. From this chronic infection, extrahepatic manifestation is the most common, and the fulminant hepatitis is rare, and the chronic active hepatitis, which progresses to cirrhosis, hepatocellular carcinoma, and the decompensated cirrhosis, mainly after 20 years of age. When we say about diagnosis of hepatitis C virus, clinically available assays for detection of hepatitis C virus infections are based on detection of antibodies to hepatitis C virus antigens or detection of viral RNA. The most widely used serologic test is the third generation enzyme immunoassay to detect anti-hepatitis C virus, and this test is at risk of being false positive and also false negative results. Anti-hepatitis C virus is not a protective antibody and it does not confer immunity, and it is usually present simultaneously with the virus. PCR assay for hepatitis C virus, which permits detection of small amounts of hepatitis C virus RNA in serum and the tissue samples within days of infection. Determining hepatitis C virus genotype is also important, particularly when therapy is considered, because response to the current therapeutic agents varies greatly. Genotype 1 traditionally responds poorly to therapy, while genotype 2 and 3 had a more favorable responses. And a liver biopsy can be done to assess the presence and extent of hepatic fibrosis and also to rule out other causes of overt liver disease. Regarding treatment, it is believed that children have a higher rate of spontaneous clearance than adults. And the guidelines recommend treatment to eradicate hepatitis C virus infection, prevent progression of liver disease and the development of hepatocellular carcinoma, and to remove the stigma associated with hepatitis C virus. Treatment might be considered for children infected with genotype 2 and 3 because they have 80 to 90% response rate to therapy with interferon and ribavirin. One approved treatment consists of 24 to 48 weeks of PEG interferon and ribavirin, and the therapy should be stopped if still detectable on viral PCR at 24 weeks of therapy. Regarding prevention, no vaccine is yet available to prevent hepatitis C virus, and once hepatitis C virus infection is identified, patients should be screened yearly with a liver ultrasound and the serum alpha fetoprotein for hepatitis C virus, as well as for any clinical evidence of liver disease. And vaccinating the affected patient against hepatitis A and hepatitis B will prevent superinfection with these viruses and the increased risk of developing severe liver failure. Regarding prognosis, viral titers should be checked yearly to document spontaneous remission. And most patients develop chronic hepatitis. Progressive liver damage is higher in those with additional comorbid factors such as alcohol consumption, viral genotypic variation, obesity, and underlying genetic predisposition. The other is hepatitis D. Hepatitis D virus is the smallest known animal virus, and it's considered defective because it cannot produce infection without concurrent hepatitis B virus infection. This 36 nanometer diameter virus is incapable of making its own coat protein, and its outer coat is composed of excess hepatitis B surface antigen from hepatitis B virus. The inner core of the virus is single-stranded circular RNA that expresses the hepatitis D virus antigen. Regarding epidemiology, hepatitis D virus can cause an infection at the same time as the initial hepatitis B virus infection, which is called co-infection, or hepatitis D virus can infect a person who is already infected with hepatitis B virus, which is called superinfection. Transmission usually occurs by intrafamiliar or intimate contact in areas of high prevalence, which are primarily in developing countries. In areas of low prevalence, the parenteral route is far more common. The incubation period for hepatitis D virus superinfection is approximately 2 to 8 weeks. With co-infection, the incubation period is similar to that of hepatitis B virus infection itself. Liver pathology in hepatitis D virus associated hepatitis has no distinguishing features except that damage is usually severe. And in contrast to hepatitis B virus, hepatitis D virus causes injury directly by cytopathic mechanisms. The most severe case of hepatitis B virus infection appears to result from co-infection of hepatitis B virus and the D virus. When we see clinical manifestation, the symptoms of hepatitis D are similar to, but usually more severe than those of the other hepatotropic viruses. And the clinical outcome for hepatitis D virus infection depends on the mechanism of infection. In co-infection, acute hepatitis, which is more severe than that of hepatitis B virus alone, is common, but the risk of developing chronic hepatitis is low. Whereas in superinfection, acute illness is rare and the chronic hepatitis is more common. When we see the diagnosis, hepatitis D virus has not been isolated and no circulating antigen has been identified. And the diagnosis is made by detecting IgM antibody to hepatitis D virus. And the antibodies to hepatitis D virus develop approximately 2 to 4 weeks after co-infection and approximately 10 weeks later after superinfection. When we see about treatment and the prevention of hepatitis D, there are no specific hepatitis D virus targeted treatment to date, and the treatment is mostly based on controlling and treating hepatitis B virus infection, without which hepatitis D virus cannot induce hepatitis. And there is no vaccine for hepatitis D till now. Because hepatitis D virus replication cannot occur without hepatitis B co-infection, immunization against hepatitis B virus also prevents hepatitis D virus infection. The last one is hepatitis E. Hepatitis is the epidemic form of what was formerly called non-A and non-B hepatitis. And the transmission is fecal oral, and it's associated with shedding of 27 to 34 nanometer particles in the stool. The mean incubation period is approximately 14 days and it ranges from 15 to 16 days. When we see diagnosis and the clinical manifestation of hepatitis E virus appears to act as a cytopathic virus, and the pathologic findings are similar to those of the other hepatitis virus. And the clinical illness is associated with hepatitis E virus infection is similar to that of hepatitis A, but it's more often more severe. As with hepatitis A virus, chronic illness does not occur, but hepatitis E virus tends to affect older patients. And hepatitis E virus is a major pathogen in pregnant women, in whom it causes acute liver failure with a high fatality incidence. And hepatitis E virus could also lead to decompensation of pre-existing chronic liver disease. Regarding diagnosis and the prevention, hepatitis E virus is diagnosed by doing antibody to hepatitis E virus particles, and IgM antibody to viral antigen becomes positive after 1 week of illness, and viral RNA can be detected in stool and the serum by PCR. A recombinant hepatitis E vaccine is highly effective in adults, but it's not functional and not used for children. This is all what I have regarding to viral hepatitis. Thank you for watching.